I'm going to discuss about indocyanine green angiography. It is an imaging modality of the choroidal circulation. Indocyanine green allows visualization through melanin, xanthophyll pigment, fluid, and lipid exudates. So it is superior to FFA in imaging the deeper choroidal lesions. Coming to the latest equipments with high resolution infrared cameras and confocal scanning laser ophthalmoscopes, ICGA can be performed. The history of ICG angiography. It was first performed by Kodak Research Laboratories to measure the cardiac output measurements. In 1969, it was used for cerebral circulation studies in animals. Then soon after that, for studying the choroid in primates. The first human ICG angiograms were performed in 1970s, and recent advances like video angiography and high resolution digital systems were developed later on. The pharmacology of the indocyanine green dye, the chemical properties, it is a tricarbocyanine anionic dye with a molecular weight of 774.96 Dalton, which is soluble in distilled water. The pharmacokinetics is, it is about 98% bound to the globulin, mainly alpha-1 lipoprotein. It is primarily excreted by the liver without any metabolic alteration. The optical properties include it absorbs light at 790 nanometer and emits at 835 nanometer. So it permits imaging through macular pigment, melanin, and blood. Coming to toxicity, the safety profile of ICG dye, it is considered safe compared to FFA with a low incidence of adverse events such as nausea, vomiting, and pruritus. The most severe reactions are anaphylaxis and bronchospasm, which are rare. There should be specific caution in a specific population where patients with iodine allergy or known seafood allergy, especially shellfish allergy, and end-stage liver or kidney diseases. In pregnant women, ICG should be done with careful monitoring, as US FDA has classified as category C pregnancy safety. Coming to comparison of instruments used for ICG angiography, first is the flash fundus camera, which is the older generation, which uses white light and barrier filters for ICG imaging, and it can capture up to 1 frame per second. The latest are scanning laser ophthalmoscopes, for example, HRA and Nidec Mirante. They use monochromatic laser light for scanning. The confocal apertures in SLO system allow selective imaging of tissue layers. SLO can capture up to 12 images per second, enabling dynamic studies. With the latest instruments capture 30 images per second. The first image is the flash-based camera, where the illumination is coming diffusely and the image acquired is has a poor resolution. In SLO-based system, slit illumination is used, where it is better than fundus camera system. But in latest confocal SLO, the emitted light is filtered through a pinhole, which allows a better resolution than the older generation systems. Coming to injection technique, the ICG dye is dissolved either in distilled water, or if performed with the FFA, it can be mixed in fluorescent sodium solution. For fundus camera based system, 25 mg of solution in 5 ml solvent is used. For a scanning laser ophthalmoscopy system, 25 mg in 3 ml is used. It is followed by a rapid intravenous injection, followed by a saline flush. In case of a known iodine allergy or a known ICG allergy, infracyanine green can be used. This is the commercially available indocyanine green, which contains a lyophilized powder of dye with distilled water as diluent and a 2 micron filter. It is diluted and taken in a 5 ml syringe, and 0.1 cc is taken as a test dose, and saline flush is loaded in a separate syringe. During ICGA, the pulse and oxygen saturation should be measured, monitored. Following the injection of the dye, saline flush should be given. Coming to phases of ICGA, it mainly divided into 3 phases: early phase, middle phase, and late phase. Early phase is characterized by the sequential filling of the choroidal vessels from larger hallux layer, saltus layer, and choriocapillaries. The first larger hallux layer, then middle saltus layer, and choriocapillaries can be seen filling. The choriocapillaries are so small that our imaging systems cannot get the detailed imaging of the choriocapillaries. Middle phase, which is from 1 minute to 10 minutes, can be further divided into first 3 minutes and from 3 to 10 minutes as early mid phase and late mid phase. It is mainly a venous phase in which the choroidal veins are filled. In this phase, the contrast differences between the choroidal vessels and background fluorescence decrease. In this phase, retinal vessels are still visible, and vortex veins can be observed in this phase. Coming to late phase, which is the last phase, about 10 minutes of injection. In this, the hypofluorescence of the optic disc can be visualized, and the larger choroidal vessels will be seen as a silhouette in the background. The background hyperfluorescence from staining of the extrachoroidal tissue will appear in this phase. In this phase, we can see the fading of the retinal vessels. Coming to interpretation of ICGA, mainly ICGA lesions can be classified into hypersynescent and hyposynescent, which can be practically called as hypofluorescent and hyperfluorescent interchangeably. The hyposynescent lesions are mainly filling defects due to choriocapillary blockade, either due to inflammation or atrophy. Blocked fluorescence due to media opacities like vitreous hemorrhage or pre-retinal hemorrhage. These lesions appear as black color. The hypersynescent lesions appear as a white color. First one is the window defect due to RPE atrophy. The underlying deeper choroidal vessels will be more prominently seen. In cases of active multifocal choroiditis, the dye can leak from the margins of the lesion, but not as prominent as FFA. Some abnormal vessel formations like branch vascular network or hairpin loops in RAP can be seen in the ICGA. Coming to some pathological conditions where routinely we use ICG angiography. The first ones are neovascular ARMD, the type 1 macular neovascularization, which is located under the RPE, corresponding to the occult CNVM and the FFA. The PED